Hi everyone, today let's learn about diabetic retinopathy and its management. So what is diabetic retinopathy? It's a microangiopathy affecting blood vessels of retina due to hyperglycemia. Pathogenesis, there is loss of intramural pericytes. Pericytes are the cells which surround the capillary endothelium of retinal arterioles, and there is thickening of the basement membrane of the capillary endothelium and progressive closure of retinal capillaries which leads to ischemia. So there is loss of pericytes which leads to breakdown of blood retinal barrier, inner blood retinal barrier to be precise, which leads to edema, leakage of fluid and edema. Then there is dilatation of capillaries which leads to microaneurysms, which are the earliest manifestation of diabetic retinopathy, clinical manifestation of diabetic retinopathy. And there is increased aggregation of platelets, capillary non-perfusion, which lead to ischemia. Ischemia will lead to neovascularization, which will lead to complications like vitreous hemorrhage. Coming to risk factors of diabetic retinopathy, the duration of diabetes is the most important risk factor. Other risk factors are poor disease control, that is poor glycemic control, pregnancy. Pregnancy is known to worsen the diabetic retinopathy status, and hypertension, nephropathy, smoking, obesity, anemia, carotid perfusion and hyperlipidemia are all known to contribute to the progression of the disease. Retinal changes in diabetic retinopathy. Microaneurysms, as I said earlier, is the earliest manifestation of the disease. Hemorrhages, macular edema, hard exudates, cotton wool spots, venous changes, intraretinal microvascular abnormalities, neovascularization, vitreous hemorrhage and tractional retinal detachments are the other manifestations. There is a classification for diabetic retinopathy which is known as ETDRS classification, which classifies diabetic retinopathy into non-proliferative and proliferative types. Non-proliferative is again divided into mild, moderate, severe and very severe. Mild non-proliferative diabetic retinopathy means any one or more of the following: dot and blot hemorrhages, microaneurysms, edema, cotton wool spots and hard exudates. Moderate means retinal hemorrhages in 1 to 3 quadrants, venous changes in not more than 1 quadrant. Venous changes consist of dilatation of veins, beading and looping of veins. Also cotton wool spots. Cotton wool spots are actually signs of ischemia due to precapillary arteriolar occlusion. They are also known as soft exudates. Very severe NPDR is characterized by 4-to-1 rule. Hemorrhages in 4 quadrants, venous changes in 2 quadrants and extensive intraretinal microvascular abnormalities in 1 quadrant. 33% risk of progression to PDR is there for severe NPDR within 1 year. Coming to proliferative diabetic retinopathy, when neovascularization sets in, the stage immediately changes to proliferative stage. It can be neovascularization of disc, neovascularization elsewhere, that is anywhere in the retina, which will lead to vitreous or preretinal hemorrhage and later neovascularization of iris and angle. High risk PDR is characterized by a neovascularization of disc of 1/3 of disc diameter, or any neovascularization of disc with vitreous hemorrhage, or neovascularization elsewhere more than half disc diameter in size associated with vitreous hemorrhage, or neovascularization of iris and angle. So let's see the causes of decreased vision or vision loss in diabetic retinopathy. These are macular edema, macular ischemia, vitreous hemorrhage, tractional retinal detachment, combined tractional and rhegmatogenous retinal detachment and neovascular glaucoma. What we have to note is that an eye with high risk PDR or maculopathy can have normal vision. That is the importance of screening in diabetic retinopathy. Coming to management. So let's see the role of fluorescein angiogram in diagnosis of diabetic retinopathy. Suppose a patient is coming with vision loss and on examination we feel that there is severe NPDR. Now we have to look for any subtle neovascularization anywhere in the retina. Fluorescein angiogram will help. This will help to find out any leaking neovascularization anywhere in the retina. And if a patient is having less vision but the fundus findings are not suggestive of any particular cause for this decreased vision, so in such cases fluorescein angiogram will help to know whether there is any ischemic maculopathy which is contributing to the decreased vision. Also we can find out the extent of capillary non-perfusion areas with the help of fluorescein angiogram. Coming to OCT. OCT is helpful in the diagnosis and detection of macular edema. It will help to qualify and quantify macular edema and to know if there is any element of traction to the fovea, and to, as a follow-up, to follow up after intravitreal injection, anti-VEGF injections, to see if there is any response to the injections, any decrease in edema or any worsening of edema, any refractoriness to treatment, etc. So, the prevention and early detection is the key word in diabetic retinopathy. So, dilated fundus examination with stereoscopic fundus evaluation is the gold standard method for detection and detection of diabetic retinopathy. So, sight-threatening retinal changes can occur even in asymptomatic patient with normal vision. Coming to management of diabetic retinopathy, tight control of diabetes and hypertension is very important. Normalize serum lipids, and coming to the management proper. Anti-VEGF injections have a major role to play in the management of diabetic retinopathy. Their main application is for the treatment of diabetic macular edema or clinically significant macular edema. The main anti-VEGF injections used these days are bevacizumab, ranibizumab and aflibercept. These help in the reduction of the diabetic macular edema. Intravitreal steroid injections, dexamethasone implant, are also used in the treatment of diabetic macular edema, especially those who do not respond to anti-VEGF injections. Another application of anti-VEGF injections is for the regression of neovascularization in proliferative diabetic retinopathy, especially before applying laser. Then the next modality of treatment of diabetic retinopathy is lasers. There are different kinds of lasers used in the treatment of DR. The most important one is pan-retinal photocoagulation, for which frequency doubled Nd:YAG laser is used. This will reduce the oxygen demand of the retina. We know that hypoxia is the factor leading to neovascularization. So, neovascularization, which will later lead to vitreous hemorrhage and tractional retinal detachment. So, if we cut the hypoxia factor by applying focal burns to the different quadrants of retina, the oxygen demand is reduced and there is less neovascular drive. So, pan-retinal photocoagulation is important in the treatment of proliferative diabetic retinopathy. There are other kinds of lasers used in the treatment of diabetic macular edema and for treating of leaking microaneurysms. Focal laser and grid laser will serve these purposes, and laser can be delivered via slit lamp or laser indirect ophthalmoscope or as endophotocoagulation during vitrectomy surgeries. So, the role of vitrectomy in diabetic retinopathy, it is especially reserved for vitreous hemorrhage which is not resolving or which is so voluminous which cannot be expected to resolve by itself, or in the management of tractional retinal detachment involving the fovea if there is premacular gliosis and if there is combined tractional with rhegmatogenous retinal detachment, and in case of recalcitrant maculopathy, which is a rare indication. End-stage diabetic retinopathy is characterized by attenuated vessels, optic atrophy, neovascular glaucoma, tractional retinal detachment and extensive fibrovascular proliferation. So, to summarize, diabetic retinopathy is a disease affecting in the retina and can lead to, blood vessels in the retina and can lead to visual loss. Eyes with severe retinopathy can also have good vision, therefore, screening is very important. Excellent control of diabetes and other systemic illness is very important for the management of DR. Thank you.